state the questions and I can answer them real time? Would that work better for you?
That would be fine.
Okay.
Somebody, Secretary, just a moment. Everyone make sure that your computer's volume is off, because we will get major feedback. You may proceed, Secretary.
Okay, thank you, ma'am. And I'm here in my office doing this by myself so I can provide testimony without a mask. But again, this week, I wanted you to know I have a few subject matter experts, our epidemiologist and vaccination lead person, lab, et cetera, in case there's questions that would be more appropriately responded to by them. Let me walk through the questions and I'll answer them as efficiently as I can. And please feel free to interrupt any time. How do I get the vaccine? Real logical question. There's really three steps to go through. One is for the person to determine what phase of the vaccination administration we're in. As I talked about last week, we've moved from phase one, which is primarily healthcare workers, long-term care, and then some essential continuity of government operations and the like. So we're now in phase two, which is the largest of the two phases. That's people over the age of 65, those that are high contact critical workers, and these are all defined online on the prioritization document. And then the third one is congregate settings. Again, the definitions are in there. So number one, to determine what phase of the vaccine prioritization schedule we're in, and we're in two. The second thing would be to come to it, ks.gov. We don't have it posted yet. We'd hope to have it in the next couple of days, which is the Find My Vaccine site, which is a map that has populated with dots of different colors for those providers that have vaccine versus those who don't. And I might have a sidebar comment on that. The federal government was supposed to have had this up and running through the CDC weeks ago, called Vaccine Finder. It's a program that exists now nationwide for finding yellow fever or typhoid or whatever. And they were supposed to have it fit out for COVID-19. They're not there yet, which is why we're building it within the state of Kansas. And the hundreds of vaccine providers and sites will be listed on that. In the meantime, we're recommending that people check in with their county health departments. And the reason is because the county health departments are the ones receiving the vaccine, and they're the ones that will direct the persons as to where to go. A lot of the county health departments, I might add, have their own sign-up programs online already and are marching right through that. I've heard as recently as today, for example, from citizens in Leavenworth and Johnson, et cetera. And then the third thing is to go get the vaccination when it's available to them. I think it would be important to mention that we're on our, what I would call kind of a steady cadence with Operation Warp Speed, who is the one dispensing the vaccine. We're getting around 45,000 doses a week. Obviously, with this phase two being the largest number of people it depends on the number of people that choose to defer or to refuse to get the vaccine. I can't tell exactly how many citizens will choose to be vaccinated, but it could be upwardly towards 800,000 in phase two. So it's the largest group. It'll take a while to march through phase two at 45,000 doses per year. You can do the math, and it's months out to get through phase two. I think that we're going to see a steady supply of the vaccine at this point from the feds. They are going to, because of the fact that we're getting 6 doses out of a 5-dose vial from Pfizer, the numbers will appear a little bit greater, but it's not because they're sending us any more vials. It's because we're managing to get 6 doses instead of just 5. So that's the answer to those questions. 1, determine your phase. 2, find the vaccination site and if there is vaccine available. And I'll tell you, it's going to be really tough sledding for a while having enough vaccine. We are getting our allocation. We're getting our 1%. Kansas is 1% of the United States population. We're getting 1% of the vaccine, but it's just not enough given the demand as we talked about. And then third is get your vaccination. Second question, find a place that is offering vaccines to the public. I think I answered that in number one, which is findmyvaccine.gov site. Third one, schedule an appointment with your local provider. The really good question, and thanks for asking it. The local providers, I should mention, are going to increase dramatically once there's a reason for them to flip the switch and become providers. For example, we have a lot of physician medical groups that have signed up to be providers, to be vaccinators. And we have a very large, when it gets turned on, when we get enough vaccine, it will get turned on, are pharmacy providers, community pharmacy providers. Yes, the CVS and Walgreens are the ones that are managing, we talked about this last week, CVS and Walgreens are the ones that are managing the long-term care facilities through the federal pharmacy program that they administer. But there's other CVS and Walgreens that will be eventually having vaccine available, and many, many other ones, Walmart, Kroger, and the like. And it'll be a real boon for Kansas because there's a lot of places that don't have a lot of medical providers, but most communities do have a pharmacy. And we're hoping that to get a maximum uptake by those pharmacies, because most of them want to be administering COVID-19 as a service to their community as well. So we're now at over 300. We could double or even triple that once we flip the switches with the community pharmacies and medical groups. And then, of course, throw in the ones that are already doing it, hospitals, hospital ambulatory clinics, safety net clinics. And, of course, the backbone of this whole operation is the local health department. I might give just a sidebar comment because, and I think this is worth talking with your constituents about. We're already seeing that the communities and the counties that have good, strong relationships between the local health department, the safety net clinics, the medical practices, are the ones that are really doing this the best in terms of cooperating. Because if somebody over here has a population of patients that they want to vaccinate that are in phase 2, and then the local health department can say, great, we can allocate to you and redistribute to you so that you can go to do that. There are some real novel arrangements that are starting to surface. One of them is the United Methodist Ministries. The bishop is working actively with us to have in communities that want to do this, to have the Methodist churches also serve as vaccinating sites. Okay, the third question was schedule an appointment. How do I do that? I already addressed that. Fourth one, who will be getting the vaccine? Do we just go to our local pharmacy and get it? And the answer to that is no, not yet, because even though we've had good sign up by the feds, and actually this is one of the things that I think that the feds have done pretty well, which is recruiting and actively recruiting in pharmacies of all different brands, as I mentioned. I think I'd have to check with our folks, but I think there's 8 or 10 chains, if you will, that have signed up. That'll really be a godsend. But in answer to the question, where do we go besides pharmacies? I talked about a public health and local public health, federally qualified health centers and other safety net clinics, pharmacies, doctors' offices, hospitals, and other health centers. What will be, oh, I'm sorry.
Secretary, sorry, Senator Hildebrand has a question.
Yes.
Thank you, Madam Chair, and thank you, Secretary. 2 questions. The first question is, what questions are you referring to that you're reading off of? Were those the ones that we had sent you?
Yeah, this is what we received.
Okay, because I thought the questions I apologize, the questions we had sent you I thought were different. So on to my second question.
Okay.
You had mentioned that availability of vaccinations, you guys are getting everything you need. But according to a Washington Post article dated January 21st, Kansas was one of only 6 states that had not been ordering their full allotment. And as of the end of that date of January 21st, Kansas still had not ordered their full allotment. Can you explain to the committee why Kansas is not ordering their full allotments?
Well, that's patently incorrect. And the reason is we've always ordered we've never had enough vaccine. That's true, but we've always ordered our maximal allotment, and we've gotten what they want to send. Now, early on, a lot of the states, most of the states did not get necessarily all their allotment because the production cycle was a little bit slow. But we are ordering everything that is allocated to us. And here in recent weeks, we've been getting everything we ordered. But there's no way in the planet that that's enough vaccine. Now, I don't have that article in front of me, but I can tell you that Kansas, we're getting 61 of the vaccine we're getting. 61% of it is already getting into patients' arms and being recorded on the data cycle as being recorded getting in. There is a bit of a data lag, and the United States in general is only 54%. So we're outperforming that. Senator, if you'd like me to, I know Phil Griffin, who heads up our immunization program, I know would be happy to answer that with a little bit more specificity about the receipt of allotment. We'd be happy to have him answer that, if it's okay with you, Madam Chair.
That's fine.
Sure. Good morning. That particular situation is there were 4,875 doses of vaccine that had originally been transferred to the National Pharmacy Program. 2 weeks into that program, they discovered that they had extra vaccine and returned that 4,875 doses to our state allocation, which immediately we ordered, but it was then 2 weeks old on the data ring. So a week later, the second doses of those became available. We did not immediately order the 4,875 second doses because the first doses had just been delivered to the facilities. Those doses came due for second dose this past weekend and were ordered at that time to match the follow-up second dose to the original first dose of 3 weeks ago. So as of right now, if you look at the same site, everything that has been made available has been ordered first and second dose.
Thank you for that explanation. That brings a question to those of us that don't understand the first dose and the second dose. Are those identical dosages, or is there some difference between the first dose and the second dose?
Phil, I'll handle that, Phil. They are the same. The Pfizer is given 3 weeks later, although it can be deferred a little bit. The Pfizer is given 3 weeks later. We call it the prime dose, which is the first one, and then a booster dose to increase the immunity further. And then the Moderna is same, except it's 4 weeks. The prime dose is 1, and the booster dose is the same strength and volume of the vaccine.
So technically, the state of Kansas could have ordered the second dose, used it as a first dose, and then on their follow-up orders, used the follow-up order as a second dose, instead of leaving that dose in CDC and not being injected. Is that correct? You can give those, yes, you can interchange those, but there's no guarantee if you use the second dose as a prime dose that you're going to get the second dose for that person from which it wasn't used as a second dose. Thank you.
Yeah, it's a good, Senator, that's a really good question in the sense that we are debating, and I don't mean just us, but the FDA and others are debating whether we should use the first and second dose and just blanket the country as much as we can with the first dose and say catch as catch can later on to try to pick up the second dose. We've not been given the authority by the FDA to do that, or even the advice or clearance to do that. But the question is, do you want to provide the most vaccine to the most people at a lower level of immunity? So there is a balancing act there to determine what to do.
So, Mr. Secretary, what is the methodology for distributing to our counties? Because I know that in Sedgwick County, we've come up really short.
The Sedgwick County, well, everybody's come up really short, ma'am. It's not based on a per capita basis. It's the second largest allocation goes to Sedgwick. The largest goes to Johnson County because of the Johnson County is a larger population than Sedgwick County. And it's by formula. It's in the and I've referred to it. It's in the matter of fact. I had this handout, this slide deck. It's in there, but it's on slide 14 of the provider manual, which has the allocation. It's basically per capita. We are allocated it by the feds on a per capita basis, and we distributed it out on a per capita basis.
Okay, so if we've taken care of the primary health care workers in our hospitals in the phase 1, then is the hospital doses, has that been delivered by the state or is that federal delivery?
We delivered that to the 5. The Pfizer was one used. That's one that required ultra cold storage. So we sent it to 5 hubs and then distributed it out on a spoke basis. The Moderna is direct shipped to anybody that gets 100 doses or more, since we don't like to break open the packs. Yeah, Sedgwick is a good example. Well, really all the metropolitan, really throughout the state is a good example that we've moved out of phase 1 and into phase 2.
Okay, well, and I think, I'm frustrated with this phase 1 and this phase 2 talk because, the announcements come out across the state that say, hey, we've moved into phase 2, 65 plus, you get to get vaccinated. And I can tell you in Sedgwick County, I have not looked at all the other counties, is we started at the 90 years of age. Now we're at the 83 years of age because of the shortage that we have. So it's really hard when people don't understand that each county is having to operate differently for whatever reason. Number 2, when people are told across the state that you can hop county lines, because then Sedgwick County, for example, doesn't know how many doses that they're going to actually have available for people from Sedgwick County. So I believe that they have made the decision that they will check identification to see if they are from a county, because you could take and overwhelm a county. So why did we do that?
Well, there's so many people that live in one county and work in another that it wasn't very practicable to send people away from their employer site, for example, when it was time to get them vaccinated. And we're all sharing the same frustration, but we heard loud and clear from local health departments, county commissioners and the like. We do not want the state to make us work lockstep and as to what the state dictates. So we want to have some local control because we know better than the state does where are our pinch points and where are our difficulties. So, and I think that's kind of what we've come to learn about Kansas in general in terms of the ability to have local self-determination with guidance. And the guidance does apply to every county. It's available to, we meet with the local health departments 3 times a week. And so I think it's been pretty clear that they have the ability to, even when they finish a phase, not to hold on to vaccine, but to go ahead and move into phase 2. Now, I guess we could be criticized for allowing for people to cross county lines, but it was one of the things that's helped to equilibrate when a certain county was done vaccinating. It didn't make any sense to deny people and put them at risk just because they work in a different county or live in a different county.
Well, Mr. Secretary, but I think that if a county ran into that situation where they had more doses than they really needed, I'm sure that they would take care of the people outside of that. But it's just created some angst, I know, in our county in particular. And how are counties supposed to know who their county partners are in distributing the vaccines because of the state distribution versus the federal distribution?
It's going all directly to the vaccinators at this point in time. That was only during phase 1 to those spoke hospitals because most of Kansas can't manage 70 degrees below 0 centigrade. So it was a way that we could prevent the vaccine from being destroyed inadvertently by counties that don't have ultra cold storage. So it was mostly a service being provided so that we could distribute it as widely as possible. Now it's going direct shipped to essentially all the vaccinating sites. The one exception to that is if they are such a small county that they don't need a full tray, of the vaccine vials, then we will deliver those in a custom manner to those people. Otherwise, they all go direct shipped right to the vaccinating site.
Okay, so okay, this goes back to then, because, just trying to figure out who we have, it appears that we've got 40 to 50 different entities representing about 150 potential dispensing points. We've got CVS, Walgreens, Dillon's, Walmart, Grace Med, and 6 are approved for the federal program and 35 are approved for the state. There doesn't seem to be any communication between the state vaccination sites and the federal vaccination sites to communicate so that they can share or transfer or handle more vaccines. So have we got a handle on that yet as to who's receiving the vaccines, whether it's from the state, whether it's from the feds, and who's able to dispense what?
Yeah, real good question, ma'am. I'm going to have Phil address that if that's okay with you, because he's the one that does the allocation and the communication about the sharing from state and fed. So if okay with you, I'd like to have Phil answer that.
Sure. So currently, all vaccines are going to the state, or excuse me, to the local health department, unless they specifically designate full allocation orders, full tray orders to another provider within the county. The federal programs, the only ones that are shipping any vaccine right now are the CVS Walgreens partnership for long-term care that is about to wrap up in their first stage or first phase of vaccine. So the first round of vaccines, the scheduled clinics will wrap up in the next 2 weeks. They continue to receive federal allocations specific to the long-term care program. All other vaccine right now is being channeled through the local health department. The local health department is made aware of the other providers within the county that they can then reallocate to within the county. So the 5 largest counties are all receiving Pfizer vaccine now, because that comes in minimum orders of 975 doses in a tray. So Sedgwick County, for example, is receiving, I believe it is 6 trays a week right now. And then if they want to take sub portions of that in the thawed state and move it to another provider that can vaccinate within 120 hours of that receipt, a group of people, they can reallocate it and move it to those enrolled providers, whether it's a state enrolled pharmacy or a state enrolled healthcare center or physician or hospital or anything like that. So all vaccine now goes through the health department.
Okay, this all sounds great and wonderful, but that's not what I'm hearing back from my county commissioners nor my county manager. They are still wanting to know who all of their partners are in those areas. And the initial delivery of vaccines were 1,400 to our local health department, 9,000 to our largest FQHC, 2,000 to our small FQHC. The large FQHC provided 8,500 vaccines to Sedgwick County Health Department. The smaller FQHC refused to release theirs.
Yes,
So
ma'am.
there's a disconnect then between what you're telling us here today and what the information is that we're receiving from our home areas. And I'm not trying to make it just about a Sedgwick County deal, and I want to hear from other members. It's just that's where I live.
Yes, ma'am, I can explain that. That was phase 1 that process worked. In phase 1, we sent vaccine to the hospitals to address all of their healthcare workers, and the initial allocations were divided between the FQHCs and the health departments, because at that time, the health departments were telling us they were too overwhelmed with testing and other matters and would be better to not receive vaccine. But we encouraged them to work together and redistribute those accordingly, which is mainly what happened in Sedgwick County, is that Grace Med sent the vast majority of all their vaccines over to Sedgwick County, and Sedgwick County moved on from that. That was all happening 2 or 3, 4 weeks ago. Currently, in the current phase, everything is going to the local health departments, and that's the way it would be going forward until we have additional vaccine available to more widely distribute.
I'll let others ask questions because I've definitely got several of them, because I'm not sure that there's still a major lack of communication. And I did have someone from KDHE visit with my county last week, and what I'm hearing here today and what they were told are two different things. Representative Epley.
Thank you, Madam Chair. And just to at least say one positive comment, I do like your dashboard. I think that's been a benefit. I hope most legislators can look at that. And as we look at the data on that, this is kind of a stream of thought question, so bear with me, Dr. Norman. But I guess my question to you is, the data that I see on there is what we're using for verification. And based on that, the experts say that we are 46th of the states at this time. And knowing that, do you feel that's accurate, or do you feel like that's still inaccurate as far as our percentage of administration? That's question one. And then question two goes back to the health departments. And if I understand correctly, because of the undersupply of vaccine, which is throughout the United States, we're now focused on the health departments distributing and deploying the vaccinations, and you're hopeful that that will solve some of the deployment issues that we encountered in phase one that Representative from Sedgwick talked about. Is that our goal through going to the health departments with the undersupply that's available at this time? Is that how we're going to solve the deployment issues? Thank you.
Yeah, good questions, both, Dr. Epley. Let me answer number two first, and that is distributing just to the health departments is practical only because we are so short on vaccine as a nation, really as a world. So it doesn't make sense to have, if we're going to have 100 doses go out, and it's a 100-dose tray, for example, it doesn't make sense to try to break it up and have it go 10 to this doctor, 10 to that pharmacy, 10 to that doctor, 10 to that small clinic. It just makes sense for them to work within their community to get vaccine into the risk people in that particular phase. We would love to double, triple, or 10 times the amount of vaccine that we have because we're just plain short. Secondly, regarding your question about where we are, again, we know that as it relates to the vaccines being administered compared to distributed, we know that 61% of the doses, this is right off the COVID tracker from CDC, we know that 61% of the doses are in people's arms, and the data demonstrates it. We know that there's a lagging in the data registering in Kansas as well as throughout the country. The WebIZ, and I know, Dr. Epley, you know the WebIZ program very well, is new to some people, and it's taken them a while to get up and running. Plus, as you also know from your legislative work, that we have communities that don't have sufficient internet bandwidth to necessarily keep up with the data submission. That percent, by the way, 61%, is better than the average in the United States. So what we need to get to those numbers and improve is we need more vaccine per capita. And yet we are getting our allocation, as was pointed out earlier by Phil. So hopefully that answers your questions number 1 and 2.
Well, thank you very much. I do understand that. I would like to see that at least those that hold us to high standards can see that this reporting issue, while it's probably not unique to Kansas, is holding us back from probably being accurately reported on where we are relative to other states. I mean, I'll hold up an aspiration of getting above the mean average, and you're telling me that, and the numbers that we have on the dashboard would indicate what they're utilizing. And so at some point, we just need to see that we have verification that's more true to what you're reporting, Dr. Norman. And I will comment, I just want to say this, that based on my phase 1 experience versus phase 2, I think there were issues with over deployment of vaccinations to the FQHCs. And I heard that from multiple counties, and that they had to redistribute back to the public health departments to get those redeployed. And it sounds like you've at least attempted to solve that now in the phase 2 by going directly to the health departments. And are you seeing less vaccine coming back, and that it's getting utilized more timely? Or can you comment about that, or can Mr. Griffin comment about that?
Let me take a whack at it, sir. Yeah, we're seeing less redistribution. And the reasons for the allocations early on with the FQHCs is that we tried to give a percent of what everybody was asking for, whether it was hospitals or FQHCs. And some didn't have good, market information, if you will, as to what number of people were going to come to them. They knew what their active patient counts were. So they tried to base their requests on what they thought would come in. The other thing that we haven't talked about, at least this week, is a number of people that are either deferrals or outright refusals. And you never know. We've had hospitals, for example, that have had 30% either deferrals or refusal of the vaccine, and that's done for a variety of reasons. So some of the FQHCs had a hard time convincing people, or they didn't sign up to come in as much as they wanted. But the good news is it was redistributed, and it didn't go to waste, and it's in people's bodies. So I think it's been encouraging that people have come together as a community to adjust to what the needs of their communities are.
Thank you, Secretary.
Senator Thompson.
Thank you, Madam Chair. Dr. Norman, I have a number of constituents who I think are under the impression that once the vaccine is administered statewide, that will constitute an end to this emergency. Do you see that as the case, or do you look to the combination of people who've already had cases of COVID plus the number of vaccines as the number you're shooting for to be able to call this emergency off?
Yeah, that's a great question. Couple things. One is that we know that the naturally occurring infection doesn't provide complete bulletproof immunity going forward. We feel that it's probably, from a naturally occurring infection, about 90 days or so is what the current school of thought is. So the question is a number of, and it's a good question. One, how effective is the vaccine at providing a durable immunity beyond 3 months, 6 months, a year, or 2 years? The Moderna researchers are telling us that it looks like a year to 2 years. If you listen then to the CDC and others, at what point, and this is really the core of your question, I think, sir, is when do we reach herd immunity where we can let our guard down? And what is traditional when we see with whether it's measles or any number of infectious diseases, you have to get to about 85% of people that have had either the naturally occurring disease or preferably the vaccine before you can say we can really start letting our guard down. But I think that's that is the light at the end of the tunnel. I don't have a crystal ball that says exactly what that date will be, but I think if we can get to 85 or preferentially 90 or 95%, either having had the illness and or the vaccine, now then we'll be a lot safer. It's not our judgment to make as to when the emergency declaration is brought to an end. Obviously, like you, whether it's for schools or commerce or everything else, we would love to get back to normal again. And I think that the vaccine is absolutely the salvation that will get us there. I might have one comment, it relates very much to what you asked, and that is just today I was looking at blood donations in the state of Kansas. Kansans are generous with donating blood. And during this period of time, we've gotten up to around 22% of blood donors are positive for the antibody. And now at the donation site, they don't tell us if it's from naturally occurring illness that they have antibodies or from the vaccine, but that's way more than the total number of cases. We've reported about 269,000 cases that have been laboratory proven. And that's a heck of a lot less than 20 to 25% that are showing antibodies. So I think there's, to your question, sir, there's more disease that has occurred out there that has been diagnosed, which is not surprising. And maybe that will assist us in getting back to normal also.
Thank you.
Senator Stephan?
Thank you all. You know, we got an email yesterday from the ks vaccine data, and I felt like it summed it up well. And the important parts to me were looking at the age groups that have received the vaccine. You know, as a physician who's battled this thing from the start, I've never felt like our leadership, the Kelly administration, the KDHE, has learned lessons from this virus and adapted strategies to it. You know, because you look at 15% of the vaccines in Kansas have been given to the elderly population, the people who have the great risk, the risk of intense morbidity and mortality. It's gone to the younger age groups, and that is an oddity to me. And then it takes me back through my whole time period with this, when in April and May, we basically closed down hospitals and turned away patients, waiting for patients that didn't come for months and months. We began using a test that the inventor said should never be used as a diagnostic test. And then we ran it here in our Kansas Department of Health and Environment labs to a point that we know we created an incredible number of false positives that led to quarantines, lockdowns, collateral damage, and collateral damage to an economy and to individuals. And we just haven't learned. We just haven't moved forward with the lessons the virus has taught us. But we have suddenly made progress in the week before the inauguration and the week after. The World Health Organization recommended a change in testing, and the cycles ran. And from everything I hear, our labs started choking that down, because we know that running it above 35 cycles in a test, we start getting a lot of false positives. And then all of a sudden, the NIH changes their stance on ivermectin. We have been starved for early outpatient treatments. We have been starved, and they've been there, and we've denied their use through the CDC, through the NIH, through our administration. And now suddenly the NIH changes their stance on ivermectin. Last week, the American Medical Journal runs an article on HCQ as a treatment regimen. Suddenly, it's changed. New York City, Chicago, California, they've started to open suddenly. What we've had here has been a combination of addressing a pandemic and a political agenda. Don't be confused about that. And it's been misstep after misstep along the way. And really, I'm unimpressed by the percentage of vaccinations that are on the shelf versus injected. There's no reason that can't be better. We need to get the vaccines in the hands of the people who can do them. It's perfectly fine in Reno County to get it to the health department, but then you need to get it to the people who actually do vaccinations and know who the patients are. That's the clinics. The health department can serve as a small repository for folks who don't have a primary care provider. The pharmacies can serve as a small repository for patients who don't have a primary care provider. But the administration is micromanaging the distribution. The administration has shown basically step after step they don't have the ability to adapt and make the decisions. We got to get aggressive with the outpatient early treatment. Enough is enough with that. Ivermectin is on the same status with the NIH as the monoclonal antibodies. So we got to get early treatments. We got to get the vaccine in the hands of the people who give them routinely, who know how to do it, and who've done it through the years, and we'll make this process run a lot smoother than it has. Thank you.
All right, committee, we've got probably about 15 minutes to before we have to wrap up. I have Representative Parker, then Senator Petty, Senator Gossage and Representative Kelly. So Representative Parker?
Thank you, Madam Chair. Thank you, Dr. Norman, again for joining us. And I apologize if this is perhaps a little repetitive. I'm just trying to get my head around what I can simply convey to constituents and folks reaching out. Just wanted to confirm a couple things. One, every county is weekly receiving vaccines from the state or from the federal government. Is that right?
Yes, that's true.
Okay. And then they can work with their own local partners within the county on distribution within the county. Is that correct?
Yes. And
Okay.
I will add a comment that there's some counties that are doing it really well by convening with the health department and medical groups and the clinics and the like. To the earlier speaker, I agree that some counties haven't really had long histories of collaboration between those entities, and it's starting to show in a negative way that they don't have those relationships worked out yet. So some counties are ahead compared to others. True.
And then lastly, just the single biggest need for getting us to where we want to be is an increase in the production of the vaccines, right? And what we receive from the federal government. Yeah,
if we could, the AstraZeneca product, it looks like is in a little bit of a slowdown mode, unfortunately. It looks like the next one coming in will be Johnson & Johnson, which, by the way, will be just a one-dose series, which will make it a whole lot easier for the reasons that Senator Hildebrand brought up earlier about first dose and booster dose. So hopefully J&J will come into the queue as well.
Thank you. Thank you, Madam Chair.
Senator Petty.
Thank you, Madam Chair. Dr. Norman, thanks for being here. And I know in my county, the health department is the primary source of vaccines administration, so they're doing an excellent job in Wyandotte County. I did have a question about when you earlier talked about, I mean, when I'm looking at the online at the website, and it talks about provider signups. So will individual providers, will they actually be receiving vaccines, or is that, you said that the vaccines are going to the health departments in those counties, but as I look at the rollout and the phases and the numbers in phase 2, for a lot of counties, is it actually going to end up being phase 3 before smaller providers are going to be receiving that, or is that determined by their relationship with the health department?
I think that more than anything, Senator, it's determined by the amount of vaccine coming in. One of the things that we don't want to do is take too small of an allotment of vaccine and divide it into too many different very small providers. I'd have to ask Phil Griffin about the logistics of when that will occur in phase 2 versus phase 3. We would love to have, to the earlier speaker, we would love to have medical groups who patients absolutely look to for advice and for vaccination. And that would be the next big echelon between community pharmacies, is to get it in the hands of medical groups. As a family doctor for 40 plus years, I've done that myself. And it would also help with the uptake of the vaccine, I think, because you're getting it from somebody that they know and trust. So we would ideally not just continue to use if we have enough vaccine, have it necessarily go to the local health department, but for now, that seems to be the best way to channel a too small amount through to a region that needs it.
And lastly, earlier you talked about the discussion, I guess the academic discussion about whether just giving everybody one shot, even though the protocol is for 2 shots. And so my question is that, so here we're talking about a certain protocol for the distribution of Pfizer and Moderna, and that, I mean, I did get my first shot, so, but it doesn't, actually my first shot, what I've read about doesn't protect me to the extent that I would have after 2 shots. So is that, I mean, I know we're not doing that, but if we were going to go that route, isn't that that's giving us a false hope, a false premise about how well we are protected?
That is exactly the horns of the dilemma, and is kind of an ethical question of what is the greater good. We are not willing to make that change. We have suggested making that change now. I'm just letting the group know that it's something that's being discussed as a potential if we keep having this slow production cycle with too few vaccines to choose from. Hopefully, we won't have to make that decision. We've not made that yet. And by the way, we use this under an emergency use authorization by the FDA. That's something that we wouldn't feel comfortable because that would be essentially an offline use of a medication from the FDA. And I don't think we're comfortable making that decision for the reasons you bring up.
Senator Gossage.
Thank you, Madam Chair. Could you give us some data, or could we find out the data on those who have had COVID and then acquired it again? Because the statistics that I am reading is that it's fewer than 50 people nationwide. So I would be interested in knowing that data.
I don't think, it's a good question, and I'd like to know that too. I know in Kansas, we've only had a handful of, a few cases that have been documented that way. And I don't know that we'll ever know that number either locally, statewide, or nationwide. We just know that it can occur. I think it's going to be rare, but certainly we're early enough in this. We've been in incident command now for a little over a year. If the naturally occurring disease causes immunity that only lasts X amount of time, 3 months or less, I suspect we'll see more of it. But there's not a common data source that has that available to my knowledge. We'd be happy to research that and come back around with that answer for you.
I would appreciate that. It would seem if we have a shortage of vaccine, those who have already had COVID might be more at the end of the line than those who have never had the disease.
And many of the people, and I referred to the term deferred earlier, particularly in the healthcare settings, many of them deferred for exactly the reason you just said, which is we have other people that haven't been infected yet, and they're in harm's way. Let's get them first, and you can pick me up later down the line. And even if we're in phase 2 or phase 3 and the people finally say, yeah, I've had the disease and now I'm ready to get vaccinated, boom, that's a good time to do it. So you're right.
I think that would be good data to maintain as well, how many people deferred for that reason.
Yeah, and it's extremely variable. We've had one hospital in western Kansas that only about 40% of the people in the first pass chose to be vaccinated. We've had others, I know some very large hospitals that are pushing 80% of the providers. And when I say providers, I don't mean just medicine, doctors and nurses, but also environmental services people, food services who are directly interacting with patients. We've had up to 80%. So I think that people are watching and waiting and seeing. Nobody's asked yet about the safety profile that we've been seeing, because we have the adverse vaccine event reporting system that we monitor anytime there's an adverse effect reported. And it's been a very, very safe vaccine to this point in time. And hopefully, as we get deeper into this, and start emerging out the other end, that people will say, okay, good. I've seen 1 million people get vaccinated. I've seen 1.5 million people get vaccinated in our state. Sign me up. I'm ready now.
Thank you. I know our time is very short. Madam Chair, I have rapid fire, a couple of other questions. I understand there's an outbreak of COVID at the Topeka Correctional Facility. How are those folks being treated?
We've had, as you know, a lot of correctional facility outbreaks. They're being isolated and cohorted together so that people that have not been infected don't come in contact with them.
But not receiving any outpatient treatment per se, as Dr. Stephan was saying. Yeah,
I don't know about it specifically in the Topeka experience. Now, we use a lot of the bamlanivimab and the Regeneron in many of the Kansas communities. I can't answer if it's being used in the Topeka Correctional Facility. I can't answer that.
And the legislators will be given the Moderna or the Pfizer? Moderna. And then I went to the ks.gov, and I'm thinking of my 90-year-old mother, and I'm seeing where you can schedule an appointment, but you have to have texting on your cell phone, which she prefers her flip phone, so she does not. It also has in very tiny print, you can talk to an actual person. So is that a live person that someone could talk to schedule an appointment?
Yes, and we can make the print larger if it's too small for
I
somebody
think
with.
it's too small. Thank you.
Okay.
All right, thank you so much. Thank you, Madam
Representative
Chair.
Kelly, and then Senator Hildebrand.
Thank you, Madam Chair. And Dr. Norman, this is a little bit different than the questions you've been getting, but it came to me just minutes before I came down from the hearing. I received an inquiry from a long-term care company in my district that indicated that on January 31st, the testing of their staff and residents, the payment to them to cover that expense was ending, and they were wondering, and for them that's about $32,000 a week, and they were wondering whether that was going to continue past January 31st, that the state was paying, assisting them with the payment of that testing expense.
It is, you are absolutely right that the free testing program in Kansas is scheduled to expire on January 31st. We've received, as you know, the CARES Act, CARES relief money to cover that until that point in time. What we would like to see is to continue with that, where people don't have any out-of-pocket expense and can have it done for just the not having a copay to bill insurance for the collection of the sample. Now that's still a little bit up in the air. We would like to see that continue, but it depends on how long the federal monies hold out.
Senator Hildebrand.
Thank you, Madam Chair. And again, thank you, Mr. Secretary, for staying on and answering these questions. My question kind of relates to Dr. Epley, Representative Epley's earlier comment. To me, it's fascinating that we have reporting errors in statistical information, and we heard you say that we're at 65, 68%. And so I was wondering, why do we keep getting different information from KDHE than what we get from the press? I know earlier you said it was, I'm going to put words in your mouth, but it was a fake article, fake news. But I just looked at another article, and I also looked at CDC. Kansas is currently ranked as of January 26th, number 50. You say we're at 68%. So I thought, well, where is this? Why are we different? Because they have us at 44. So I pulled up the email that I received earlier, and it says that Kansas has administered 157,200 or 520 doses. CDC has us at 158,743. So I would think if we have a reporting issue, that CDC would not have us administering 1,000 more. So then I looked at distribution. According to your statistics, we're at 255,550. But according to that same CDC site, as of today, it's 348,175. Help us understand where CDC is wrong and your numbers are accurate, because it doesn't add up. If there's going to be a reporting issue, if the reporting issue is the problem, it'll be on the doses administered, not doses received. But CDC says we've received over almost 100,000 more than what KDHE is reporting. So help us understand that reporting error.
Yeah, good question. We consider what's in WebIZ to what we know to be true, because that's, we're not administering the vaccine at the state. The local and the counties are administering it and putting it in. We depend heavily upon the 105 counties or the 103 health departments to enter it in. And we think of the WebIZ as a source of truth. So and we'll stand by those numbers. With your permission, Madam Chair, I would like to ask Phil, because that gap that you talk about, Senator, between 255, 550 and 368 or whatever it is, I can't explain that with what I have in front of me, and I don't necessarily review all those data every day, but I would like Phil to address that if you would allow that to occur.
Mr. Secretary, if I could, I don't think the issue was WebIZ and reporting. That's why I brought that up, that those numbers are really, really close. The issue is what KDHE is saying we've received and what the CDC says we received. There's almost 100,000 dosage difference. That's what I'm trying to wrap my mind around. Why is that different?
And that's exactly what I would like Phil to address, because he knows how the data flows. We haven't even gotten about Tiberius yet. Tiberius is a federal system that the Operation Warp Speed has. It's completely different from WebIZ and from what the CDC uses. And Phil lives in the system Tiberius, which is where that 368 comes from. That's why, if with your permission, Madam Chair, I'd like him to comment on that discrepancy.
CDC told us last night they changed on January 20th the mechanism for which they are counting those, and it's actually shipped doses now. And those, the difference of the 92,000 is what has been shipped into the National Pharmacy Program. That is not directly come to the state of Kansas through our allocations, but it's what's been transferred to them, and then they have ordered out of the allocations that was transferred and shipped to CVS and Walgreens.
So that's the direct shipment to long-term care that the state, that we don't ever really process or have our hands on within the state. That's the gap then.
Okay, then that brings up a follow-up. If your administered doses is that close, does CDC record those administered doses as well with your doses? Or, because if they're keeping track of the dosages sent out and you're not, because it's going through a Tiberius program, federal sending out, how do they know what those dosages have been administered?
Yeah, Madam Chair, with your permission, I'd like to have Phil answer that, since he's the one that stays closest to those data.
That's fine.
Yeah, those doses go into a CDC data lake, is what they call it. And so it's coming from a variety of different sources. And yes, they are getting direct information from CVS and Walgreens. It goes into a data lake, and eventually that feeds back into our Kansas WebIZ as well. There's 3 different reporting mechanisms that people can get data into the systems, and that is through a direct entry, through HL7, which is an electronic transfer from the health system's electronic health records. And then a third way is through a flat file transmission that gets uploaded. And so all of those compile and hit the data lake and goes through and back out to the different systems at various times. Some of the time the issues are a matter of data lag of getting the data in. Other times it's a matter of the reporting of it pulling out of there.
Okay, thank you. So basically what you're saying is the CDC numbers are correct, KDHE numbers are lagging, and therefore we are ranked number 50. Thank you.
All right, Secretary, you brought up the TBRIS, which is the national database for the long-term care facilities, which are partnered with CVS and Walgreens. In Kansas, we have approximately 720 LTC facilities licensed, but it looks like that we're only addressing about 600 and maybe 80 of those facilities. So we're short on 60 of them. And I think we heard a little bit of that last week, that not all long-term care facilities are created equal, or in how they're identified. So how are we addressing the issue that was brought up on the approximately 60 that are not in the normal realm of where CVS and Walgreens would be addressing?
Yes, good question. The allocation of the vaccine to those that are not within the national program comes from the state and goes to the counties. And because those facilities typically have pharmacies that they have contracts with, not CVS, not Walgreens. Yes, you're right, 684 sites are the ones that we are tracking. And we know, for example, that as of this date, about 60 to 65% of the residents and 40 to 45% of the staff through CVS and Walgreens have gotten them. And that by the end of the month will be the remainder of those in the federal program. Now, we don't have any exact tracking mechanism in place. We don't know, for example, when a patient that's in a group home, for example, gets a vaccine, we don't know that they're in a group home. because they get entered into WebIZ by their address and age and those kind of demographics, but we don't necessarily have visibility. That's why, again, back to the local organizations, counties, and communities, we want to make sure that they gather up those ones that are not part of the national program, and they're in phase 2, so most of those patients would be qualified for the vaccine now. We believe that they are in the process of getting those.
So are you saying those 60 some are being addressed by the counties?
Yes, by the counties and ultimately by local pharmacies that have the contract with them.
With the counties?
Yes.
All right. That's not the information I'm getting. I think we still got a gap with that, so I think we need to visit on that further. Committee.
Can I address that to provide a little bit more clarity? Our staff actually in the last 2 weeks has been reaching out to those individually, and there were several shipments that went out that last week and more going out this week directly to pharmacies and local providers that are partnering with those long-term care facilities that were not in the national program. So those are actively in process right now.
Okay, and this goes back to, and I think Senator Hildebrand kind of hit on it, and this is where I've gone, is that the questions that I'm asking you today were fresh as of 8 o'clock this morning as I visited back with my county. So there is a major disconnect with what you're telling us and what we're hearing back from our counties. And I think it would be important, legislators, if you haven't done so, is maybe visit with your counties and find out exactly what's going on with them. Did you have something, Senator Baumgartner?
Thank you, Madam Chair. That just gets us back to where we started last week and where we ended. And the concern was that lack of communication, not only with the KDHE, but also and those assisted living or those long-term living facilities, but the lack of communication between KDHE and KDADS. Somewhere along the way, even if it's not in the federal reporting system, we should be tracking to make sure that those congregate living facilities are most vulnerable and at risk are elderly and living in a shared facility. That makes them doubly vulnerable. The fact that we're not accurately tracking where we are on each of those residents, because that is their home here in Kansas, is troubling. Thank you, Madam Chair.
All right, committee, I wish that we did have a little bit more time. Mr. Secretary, I do appreciate you appearing with us today, and I'm sure that you'll be hearing from us in the near future. So committee, we're adjourned.